In this lecture, we are going to look at the different clinical types of psoriasis and probable management. Now, the first is chronic plaque psoriasis, which is also known as psoriasis vulgaris. The most common type seen in 90% of psoriasis patients, it may present as coincised known as nummular psoriasis or large size lesions known as psoriasis geographica. These are well-defined erythematosquamous plaques which tends to be distributed bilaterally and symmetrically. The next point is the type of scales. The type of scales that you get in psoriasis referred to as micaceous silvery white scale, and the distribution is predominantly going to be on the extensor aspect of the body and usually over the bony prominence. So the site is going to be on the extensors, elbows, knees, and other site involves lumbosacral area and back. Now see, this is classical psoriasis. Erythematous scales, papules and plaques. Micaceous silvery white scale distributed over the extensor aspect of the body. Now let's look out some named features in psoriasis which we need to remember. Number one is a clinical sign which is known as Auspitz sign. Second important feature which is named as Koebner's phenomena. And number three, a named ring in psoriasis which is called as Woronoff's ring. So what is Auspitz sign? See, we take a glass slide and we are going to scrape the lesion of psoriasis. This test is called as Guttate test. So when you scrape the lesion of psoriasis, characteristically coherent, giving the appearance of a scratched wax candle, or we can say the silvery white scales. If you continue with this process, after some time you will get a membrane. This membrane is called as bulky membrane. And further, if you continue with the scraping process, you are going to land up with pinpoint bleeding spots. And all this step together known as Auspitz sign. Okay. The next important named phenomena is called as Koebner's phenomena. The Koebner's phenomenon first described by Henrik Koebner in 1878. Now, Koebner's phenomenon is also referred to as a isomorphic response, that means similar morphology. It is defined as appearance of morphologically similar lesions along the line of trauma in an uninvolved area of skin in a psoriatic patient. Koebner's phenomena is further classified into three types. Number one is true Koebner's phenomena, second is pseudo Koebner's phenomena, and third is rare Koebner's phenomena. Now, what is the mechanism of true Koebner's phenomena? True Koebner's phenomena is immunologic and can be seen in three important conditions of dermatology. Number one, psoriasis. Number two, lichen planus. Number three, vitiligo. Now, what is the mechanism of pseudo Koebner's phenomena? Pseudo Koebner's phenomena happens because of autoinoculation, and it has to happen because of the viral infections. The two important examples to remember here is number one, molluscum contagiosum, and number two, viral warts. And the last is rare cause of Koebner's phenomena. Number one, Kaposi sarcoma, and number two, Darier's disease. Now, the third named feature of psoriasis is Woronoff's ring. What is Woronoff's ring? See around the lesion of psoriasis. You can see there is a hypopigmented rim. This is called as Woronoff's ring. The second important type of psoriasis we are going to discuss here is Guttate psoriasis, where the word gutta means raindrop. This form of psoriasis accounts for roughly 2% of total psoriasis cases. This Guttate psoriasis is usually occurs in children, and there will be history of sore throat. So when I say history of sore throat, that means pharyngitis, tonsillitis, or we can say URTI, upper respiratory tract infection. It implies group A beta hemolytic streptococci infection. It is characterized by tiny raindrop-like erythematous papules erupting abruptly in the centripetal fashion and distributed symmetrically over trunk. The palm and soles are usually spared. See in this picture, you can see small raindrop-like lesions over the trunk. So, what is the drug of choice for guttate psoriasis? Although the prognosis is usually good and the lesion tends to resolve in 3 to 4 months. Now, because it was triggered by a streptococcal infection, the drug of choice has to be antibiotic. And here we are going to choose the macrolide group.